with Jessica Rockwood, we are the chairs of AMP's Innovation and Evaluation Working Group. We are very pleased to present this webinar today to launch a series of case studies that we've developed related to AMP support to ITN distribution in humanitarian settings. There is a number of case studies that are now on the AMP website that we'll direct you to. But today we're going to hear from particular AMP partners who are working in humanitarian relief settings and to understand the operational changes that they've made to address the challenges that are faced within those particular crises. So, and on top of that, we're also going to hear work that the UN Foundation has done, helping to better map the incorporation of IDPs and refugees into Global Fund grants and better mapping of where refugee populations are located in comparison to malaria incidence and prevalence rates. So on behalf of, again, on behalf of myself, Jess, Dana, Dr. Jim, and Sajid, thank you all for attending this webinar today.
So just Joe, if we can just inform people that interpretation is available. Thanks.
Oh yes, of course. Sorry.
Interpretation is available. If you are able to go to your the settings on this on Zoom, you will see the opportunity for this presentation, which will be given in English, but to be translated through simultaneous translation into French, and I believe Portuguese as well. Correct, Elisa?
Yes, Joe, and just say, sorry, pour les francophones et les lusophones, je parle pas portugais, mais pour les francophones, vous pouvez aller dans la barre en bas de votre écran, dans interprétation, et vous pouvez avoir l'interprétation en français. Voilà, merci.
Merci, Elisa.
Okay. So
just setting the stage very quickly. I know many of you recognize this as organizations and individuals who are working often in challenging environments, but the world today, we're really at a crisis point from an IDP and refugee standpoint. We have an increasing number of IDPs and refugees, almost 90 million of them displaced worldwide. Almost over 27 million refugees, so people outside of their home country, over 50 million internally displaced people, and this number is continuing to grow from both natural and conflict causes globally. So when we look at the kind of displacement and where this is happening globally, we see that over 40% of it is happening in sub-Saharan Africa, and over 50% of it is happening in areas traditionally identified as malaria endemic. So these populations represent a huge challenge to our ability to meet malaria elimination goals and control goals. And our ability to meet these populations are often challenged by the access to certain commodities, including vector control commodities and nets that are often the best life-saving measure that we can provide to them. So we know that there is a lack of information that is available often at country program levels, and our ability to bridge from a malaria program or a vector control program to the humanitarian clusters or others that are working within countries is often difficult. And we're starting to see more information being available. We're starting to see it from the malaria standpoint in things like the World Malaria Report, where they are identifying where particular armed conflicts are happening, and things like where flooding inundation is occurring. Two types of kind of environmental and humanitarian crises that often have major impacts on malaria transmission and our ability to fight that. But we know also that more and more detailed information is absolutely needed for countries to make the right decisions about what adaptations are needed to be able to get vector control products, especially ITNs, to these populations. So here is just an overlay of where we see malaria incidents and displaced populations happening. This is a very quick snapshot, which we'll go into more from our folks at UN Foundation, who have done a much more detailed analysis of this from this initial mapping that they have done. So we're really excited to share that with you today. Just to say from the humanitarian side, the lack of access to malaria prevention commodities is recognized. So from the UNHCR report in 2021, they recognize that malaria prevention is lacking. So we both see that there is a need from the vector control side of the coin, but also from the humanitarian response side, that they also recognize that a lack of malaria prevention support is creating health gaps and disparities among IDPs and refugees. So finding bridges among both the vector control community and the humanitarian response community is going to be crucial for us to meet these ongoing challenges. So just a little bit about what AMP has done to date. I think everybody recognizes the tremendous work that AMP does at country level by providing technical assistance to countries. Often, many of the times, and many of the countries that technical assistance is being provided to are in what are Global Fund designated COE countries, or in countries that are experiencing a humanitarian emergency, or just coming from them. And obviously that level of support continues to be different in different categories, depending on where they are in their ITN campaign process. This quick kind of graph is actually the 2021 TA provider list, and we know that in 2022, even more technical assistance has been provided to conflict areas, and is continuing to in areas like Pakistan, Nigeria, and others. And as well as, and something that AMP continues to do, is to provide technical guidance for adaptations needed in COE environments. So just to recognize that there is this operational guidance available on the AMP website around operational on ITN distribution in COE environments. And these case studies that we'll be talking about today, we hope complement both what is in the COE guidance document, as well as highlighting the in-country work that AMP has provided through its technical assistance providers. Just to note that this has also been, there's been a number of global initiatives to date, starting just tracking from the development of the Malaria Control and Humanitarian Emergency Handbook from WHO, as well as a number of different meetings that have been hosted that try to elevate this crucial gap on the global agenda, ones that happened right before COVID. And now from this, that we've now continued to see bigger gaps emerging within the space, the reemergence of this discussion on a global forum. So recently, AMP, CRS, UN Foundation, and RBM held a roundtable, the first of 3 roundtables. We held this in Washington, DC at the beginning of September to bring together malaria and humanitarian response partners, donors, and others to try to bring this crucial topic back on the global agenda. So the purpose of our first roundtable was really to outline and engage and promote better cross coordination, which I think we achieved. The second was to ensure that partners continue to address the bottlenecks that are frequently seen in delivering vector control commodities in conflict areas. And then the third is looking at identifying funding opportunities. We know that often it requires more funding, more coordination across partners to ensure that these commodities meet these hard to reach populations. and bringing together the right partners to address this in a critical way was important. The meeting was very well attended, with over 40 people attending in person and online, but mostly on person. And here are just some of the key takeaways from this first roundtable that I just wanted to quickly highlight with you. I think one of the things that really came out was the fact that there is low quality and poor data that is often seen within these COE settings, within these populations. We need new financing mechanisms to respond more quickly. And there was some very good discussions around what those could look like. Shelter plays a huge role in providing a barrier for vector prevention, as well as an opportunity to do things like hang bed nets within there. So how can we better coordinate with our shelter colleagues to ensure that as we try to increase access to vector control commodities, that we're also doing that in coordination with shelter folks. Again, this idea around disaggregated refugee and IDP data are extremely rare, but I'm excited for you guys to see some of this UN Foundation work that they've done here in just a second. There are other opportunities for us to partner with, including opportunities within the vaccine initiatives, including what they're calling zero-dose children who have received 0 vaccine doses, and what are the steps that we can take to ensure that children are vaccinated, and how can we look at partnering with those type initiatives, both learning from what they are doing in terms of access to those, or finding synergistic ways to work with them to ensure that ITN's other vector control products are being distributed. Tracking the flow of resources for humanitarian conflicts is hugely complex. We know it's often very difficult to get commodities sometimes into countries to respond to this. And we know that there is need for improved mechanisms to get commodities into these challenging environments. And finally, the role that community health workers play in COE settings, we know is often incredibly challenging, but is a crucial health source for us to ensure that commodities get to these right populations. So I hope that provides just a little bit of a snapshot and an overview of the context and what's been talked about globally to date. And we're, again, very excited to launch these case studies, and also to hear from UN Foundation on the malaria displacement maps that they've developed. After we have this, we'll have opportunities for question and answer discussions on both the case studies that we've developed, as well as our plans for future global engagements around this topic. But we look forward to hearing your suggestions around other opportunities that we might have for providing particular channels for discussing this topic with other groups, as well as seeing how other partners within the AMP partnership can be better involved as we try to elevate this agenda. Please feel free to put any questions in the chat. We'll try to monitor those as well, but we do ask that those people with questions come off mute and ask their questions to the group when that time comes up. So with that, I think I am done. Again, welcome. Thank you again. We'll spend the next about hour and 15 minutes going through. We'll spend the next hour or so, 45 minutes to an hour going through this, with then time for questions and answers. Okay, so thanks again. And I think over to Dana. Dana, please just feel free to say.
I'm sorry.
Sorry, is that about the interpretation, Elisa?
Yeah, I think so.
Can you please repeat? Sorry. Is there a problem with the Portuguese interpretation? Chris? Wait, I'm gonna go. Hello? Is there a problem with the interpretation? Okay. All right, I think we are good. So let's go ahead.
Great. Hi, everyone. My name is Dana McLaughlin. I'm a senior associate on the global health team at the UN Foundation. I'm joining here today to share some of the work that we've conducted, a recent analysis that we've just recently finished to examine the inclusion of displaced populations in Global Fund applications. This is an analysis that we've conducted for the past 6 years, and the most recent iteration is now available. We'll be sharing the links for this analysis at the conclusion of the presentation today. But just to get started, the reason behind this analysis and really where this work was born out of conversations about how to strengthen the inclusion of migrant and displaced populations in malaria programming, both at the multilateral and bilateral and national level. So, WHO's global technical strategy for malaria is centered on the principle of equity. And this work was started many years ago in conversation with core malaria donors like the Global Fund, PMI, National Malaria Control Programs, to identify the need to prioritize and fund targeted malaria activities for migrant, marginalized, and last mile displaced populations. So I'm going to get into a little bit about the analysis and then show some of the findings from the most recent update. So next slide, please. So just as a source of background, and I think it's important to note this before we get into the findings, malaria remains a leading cause of morbidity and mortality among refugees and IDPs. Almost 2/3 of refugees, internally displaced persons, return refugees, and other persons affected by humanitarian emergencies live in malaria endemic regions. We recognize that this analysis that looked at the mention and inclusion of written activities for refugees and IDPs in funding requests is an imperfect proxy. Some countries very likely include these activities for their populations without mentioning them in their applications to the Global Fund. However, we felt like this was a needed analysis to examine the inclusion to date and also identify areas for continued strengthening of targeted activities for displaced populations. This most recent analysis is building on 2 past analyses that were conducted to look at the 2014 to 2016 funding cycle, and then also applications from the 2017 to 2019 cycle, all of which are available online. We have a microsite that has all of the data and individual scorecards that were developed for countries. This most recent analysis looks at the inclusion of refugees and IDPs in the 2020 to 2022 funding cycle. And this analysis is bigger than malaria. It also includes HIV and tuberculosis. However, for today's presentation, I'll just be focusing on malaria. Next slide, please. So just a brief recap of some of the methods that were used. These are the key search terms here on the left-hand side of the screen. The eligibility for analysis of Global Fund funding requests was determined by 3 factors. The country must have qualified for Global Fund allocation during the 2020 to 2022 funding cycle, had at least 1 approved grant application during the funding cycle, and had a refugee and or IDP population of greater than 10,000 at the time of the application. The year-end refugee and IDP population data were utilized for all the 3 analyses that have been conducted over the past 6 years. And the refugee data was accessed from UNHCR's Refugee Population Statistics Data Finder, and IDP was accessed from the IDMC displacement database. The populations of concern, which I'll get to in a minute with the map, was developed using UNHCR's ArcGIS Hub, which is publicly available data that's available, and we were able to use their data to recreate these population of concern maps, which I'll show in a minute. And then national malaria case and death data were accessed from the 2021 World Malaria Report. So next slide, please. So getting into some of the findings from the study, and here on the screen, you'll see a comparison between the previous analysis that was conducted looking at the 2017 to 2019 funding compared to the 2020 to 2022 results. You'll see this is just overall the total number of applications that included targeted activities for migrants, refugees, and IDPs increased quite considerably, which is a really promising sign. I'll get into some of the disease-specific improvements later, but this is just a 10,000-foot view snapshot of the analysis. And the most recent analysis included 100 applications from 37 countries who met those criteria for refugee analysis and IDP analysis. And while our policy analysis and advocacy have triggered some progress, there is still room for improvement here. And that's what I'll get into as I talk about some of the malaria data. Overall, the targeted activities for last mile and displaced populations increased from 36% to 81% for refugees and 17% to 69% for IDPs. So while the tremendous progress has been made, there's still some room for improvement, particularly as we look into the disease-specific applications. Next slide, please. So since the last funding cycle, as I mentioned, the inclusion of targeted activities, which is identified in the green for refugees and IDPs, has increased substantially. And in fact, the number of applications mentioning displaced populations without detailing activities targeting them has also decreased. So that's what is shown in the yellow there, which is a quite notable finding, considering that in the past, we saw very often country applications identify that they have considerable refugee or IDP populations, but not design targeted interventions for those populations. And now in this most recent analysis, we saw a dramatic shift to countries recognizing the populations and also designing targeted interventions for them, which is promising. Next slide, please. So getting to some of the specifics for malaria, as Joe referenced, next slide, please. As Joe referenced, part of this analysis included the creation of maps that overlay displacement data and populations of concern with malaria endemicity. And the incidence shown here is just for Plasmodium falciparum, but we also have a separate map for Vivax as well. This map is something that is a tremendous resource, not just for advocacy, but also for the discussion about the need to strengthen inclusion of refugees and migrants, specifically in certain countries where we see a high overlap of refugee and IDP populations with malaria cases and deaths. If you go to the next slide, that will also show a more detailed map. And we have these maps that are specific to each region. This is just a zoom in of the sub-Saharan Africa map, but there are very specific maps for Asia Pacific and also for Latin America and the Caribbean. Next slide, please. Yeah, so this is the Vivax map that I briefly mentioned, obviously a bit different shifting of focus, and our regional scorecards that have been developed in correlation to this map identify the different interventions that are needed to address malaria in different parts of the world. Next slide, please. So looking at malaria specifically, as I mentioned before, we've seen the increase for specific malaria activities for refugees and IDPs. And kind of quite notably compared to even the two other diseases, the number of funding requests that mention displaced populations without detailing targeted activities has been a huge improvement for malaria. The results for HIV and TB are also quite promising. However, malaria by far has the most dramatic increase in the inclusion of refugees and IDPs. Next slide, please. One of the other things that we've done is create these a bunch of resources that identify the changing nature of displaced populations. As we all know, the nature and the makeup of displaced populations changes frequently, and therefore the interventions that meet the needs of these changing populations must also be adaptable. And so one of the things that we've done is map not just the population size and makeup, but also identify ways that countries can use this data and these resources to respond to the ever-changing needs of migrant populations. So this slide compares the population size and the mention And then if we go to the next slide, it shows the updated analysis from 2020 to 2022. So you see a lot of those yellow dots turn green, which means a lot of the countries that previously had just mentioned the presence of refugees and IDPs took a next step in the most recent funding cycle to include targeted activities, which is incredibly promising and something that we can continue to build on as we think about the upcoming Global Fund funding cycle. And this is just for refugees. If we go to the next slide, it shows the breakdown of population data and mention for IDPs. Obviously quite different makeup of the population here. And then if we switch one more slide, it shows the change there. Again, quite dramatic move from many countries that were previously with yellow dots to green dots. And it's also really interesting to see as you move from country to country and as you move from region to region, how the makeup of the population changes. So some regions have quite dramatic IDP populations, while others might have more longer term refugee populations. So the nature of the population, of the displaced population itself, also directly impacts the type of interventions and activities for malaria that are requisite. Next slide, please. So one of the other things that we've worked with both UNHCR and the Global Fund is to develop targeted recommendations for each of the disease areas, and then also holistically as countries start to prepare their next applications, to really understand what are the barriers and the types of the steps that countries can take to effectively address the malaria needs of displaced populations, and also identify some key recommendations and resources for countries to draw upon as they're putting together their new applications. We also recognize that countries, like many of those that you just saw in the maps, that have existing and newly displaced populations who already are conducting activities or are already including activities for these displaced populations in their funding requests, that they should continue to consider adaptations and opportunities to strengthen those interventions so that the populations can continue to benefit from the full package of malaria services that are necessary to keep them healthy and safe. And especially when we think about refugees and IDPs, we also need to give special attention to ensure effective inclusion and coverage by addressing socioeconomic, cultural, language, gender, and other barriers that take place that prevent them from accessing malaria interventions and other health interventions as well. Next slide, please. So what we've done here, and in the past, we've created targeted country-specific scorecards. However, this time, per the recommendation of the Global Fund and UNHCR, we've created regional scorecards. So we can go through the next couple slides quite quickly. They're just a snapshot of the results for each country. But we've done this intentionally because we felt that the regional approach was effective in the sense of addressing the larger context of displacement in the region. As we know, so often displaced populations are often not staying put, but rather moving from country to country. And so we felt the regional approach was a more effective way to address the populations of concern and also identify what trends and what progress the regions have made to strengthen the inclusion of targeted activities for refugees and IDPs. So that's just a screenshot of some of the regions. We've used the UNHCR regions to develop these scorecards. So there's now 6 scorecards that are available. They will be linked automatically to the refugee data as well. So this is just a snapshot of what the scorecards look like, updated from past scorecards to include a bit more about the humanitarian situation and a regional overview, in addition to the more disease-specific breakdown with higher quality maps for both malaria, HIV, and then we're working on the tuberculosis maps as well. Right now, we just have the malaria and HIV data. So this is, you go one more slide. The scorecards are 4-page each. They'll be available digitally and printed as well, and we'll be distributing them at upcoming opportunities for engagement and conversation about this analysis. But really, kind of going back to the reason of this study is to create and to generate evidence so that we can effectively continue to effectively inform policymaking and financing decisions, as well as country level planning and allowing countries the tools and resources to use this data to inform their decisions as they prepare for the next funding cycle for the Global Fund application cycle. So that is all. I'm happy to answer any questions. I will share the links after this conversation to the microsite where these scorecards live, and also happy to answer any questions about the maps or the analysis itself. Thanks.
Dana, thank you
so much, and a tremendous amount of work we know from the UN Foundation and UNHCR that is going to be beneficial to country programs in the planning of their NFM4 grants and the activities that they're doing at the country level. So Dana, thank you so much for that presentation. We'll have opportunities to ask Dana questions in a little bit. Again, keep putting them in the chat if you have them, and we'll take a look at them. But I think we'll move into our presentations related to the case studies that we developed. The first is from Mentor Initiative, Sajid Kamal, who is Mentor's country director in South Sudan. I just wanted to quickly mention the work that Mentor has done is going to actually focus on integrated vector management. It's a little bit different than the case study that's written because we weren't able to get the correct group on to participate today for the case study that we wrote about South Sudan. That being said, the adaptations that Mentor initiatives have made in South Sudan, I think, are reflective of the context within that country and parallel nicely with the case study that's been developed. So Sajid, over to you.
Thank you so much, Joseph. Thanks for the opportunity. As you mentioned, that Mentor Initiative has been working in South Sudan. Yeah.
If people are able to mute themselves, that would be appreciated. Thank you.
So Mentor Initiative in South Sudan has been working since 2012 and mostly like doing integrated vector control management activities in the IDP and the POC sites and in the refugee camps in South Sudan, and to some extent in the nearby host community. So next slide, please. Okay, so currently Mentor is operating in 2 IDP sites and 6 refugee camps. The IDP sites are in Bentiu and Malakal, and the current total IDP population in South Sudan is 2.2 million. 78% of them are residing in the IDP camps, while 22% are residing in the nearby within the host community. Bentiu IDP camp was created in 2013, and it is the biggest IDP camp in South Sudan, hosting around 120,000 IDPs. 24% of them are children under 5. This Bentiu is naturally a lowland. It's poorly absorbs the water, so when you come in the dry season, you will get a lot of dust there. But when you visit Bentiu IDP camp in the rainy season, there will be water everywhere and flooding as well. And currently, if you look into the IDP sites from above, it will look like an island surrounded by water because of the flooding last year and the fresh flooding this year. So Mentor started operations in Bentiu IDP camp in 2015. And since then, we have been doing vector control intervention, which includes IRS, larviciding. We also do awareness raising, and we also do fly control. The shelter in these IDP camps are mostly made of local materials like wood, plaster with mud, and in some cases tents as well, and having some kind of corrugated metallic sheets as roofing. So IRS is conducted as an emergency response. LLN distribution is being done by other partners through Global Fund, with other subrecipients. So mentor is not part of the Illy line distribution in South Sudan. Funding for the Bentio IDP, we have been receiving funding from UNICEF from 2015 to 2018. And there are some in-country funding mechanisms, which are RRF and SSHF. So they've been funding us for quite a number of years. Next slide, please. Next. So as I mentioned that this Bentio is quite huge camp. So whenever we do IRS campaign, we do it just before the start of the rainy season. And we involve the local community hired from within the IDP sites. So normally our IRS team is comprised of 5 spreads, 5 mobilizers, and 1 supervisor and 1 water porters. And we train them for 3 days. The mobilizers are further trained to collect data on different IRS indicators and also dissemination of the awareness messages. We also implement a door-to-door campaign together with the IRS. And WHO guidelines says like more than 85% of the shelter need to be covered. But based on our experience from 2015 up to now, we have been covering between like say 95% to 100% of the shelter within our target areas. So we have been switching insecticides regularly. I'll come to that later. We have conducted susceptibility tests in 2015 and 2018, and based on those, we switch our insecticides from on regular basis just to avoid development of resistance. Next slide, please. Next. So we also do larviciding. So larviciding is mainly a supplementary activity that is conducted during the dry season and when the breeding sites become few fixed and fireable. So basically we train the community workers. Our team composition includes like 5 applicators and 1 supervisor, and we do breeding site mapping, and then we conduct larviciding campaign. So when you see the Bentio IDP camps, it has 5 blocks. Each block is divided 5 sectors, sorry, and each sector is divided into different blocks. But waste water channel surrounds these sectors. So you will also you will find mosquito breeding sites actually throughout the year, even in dry season. So normally we conduct larviciding campaign during the drier month. Next slide, please. So this graph shows the impact of IRS campaigns over those years from 2015 to 2022. In 2015, there was an upsurge of malaria cases, and we were asked to come and intervene. So we were present in other areas. So luckily we had supplies ready. We went and we intervened, and we used ICON. Illy line distribution was also conducted by then. And actually the IRS was a bit late, like it was conducted in week 35 to 38 when the rainy season was also on. And we know that the rainy season is coincide with the malaria transmission season, but still, if you see a reduction in malaria cases, what it can be seen after IRS was conducted. Then 2016, we used again Illy Alliance and IRS, ICON, and you can see the malaria cases has reduced, but that IRS was also conducted a bit late because of the funding cycle issues. From 2017 onwards, we received funding on time, and every IRS campaign was conducted before the rainy season. So the impact can be seen here, like say in 2015, when we intervened, there were 188,751 cases by that year in the PUC, and in 2019, when we temporarily stopped IRS campaign due to lack of funding, we brought malaria cases into 48,332. So we struggled to get continuous funding from 2019 onward. In 2020, we were not operating in Binti IDP camp. So the malaria cases reached to an alarming level, and then everybody was just kind of panicking. PBU-LIN was distributed by UNICEF, but it was not enough to control the malaria cases. Then through RRF mechanism, we received funding, and then we implemented IRS campaign, and it can be seen from in 2020 that right after the completion of IRS campaign, the cases started decreasing. So 2021, we again did IRS campaign, and the result can be seen. And now in 2022, recently we have conducted IRS, but this year in 2022, 2021, and 2020, we have used Sumishield, and we are planning to switch over to Fludura Fusions in the next round of IRS campaign. Next slide, please. Malakal PUC is the second largest PUC site. Actually, Bentiu IDP camp has been converted basically into IDP camp, but this is the only remaining protection of civilian sites in South Sudan. And it can be seen from the picture that the shelters are not as organized as those in Binti IDP camp, and the hygienic conditions are very bad. In a recent study, it has been found that 26% of the population in Malakal have no access to solid, liquid, or powder soap. So you can imagine. So population of Bentiu PUC, currently it is hosting 34,396 individuals, and majority of them are children under 5. That's the shelter you can see like made of corrugated iron sheets together with plastic sheets. So anything they could find there, they make their shelters from that. And there are some mud and thatched shelters as well. Significant overcrowding, as I mentioned, is there, and no drainage system, and extensive flooding is experienced during the rainy season. Currently, there has been an insecurity going on in the nearby county, and this IDP camp was made to accommodate 15,000 IDPs, but now we see that there are 3,096 individuals, so it is very much overcrowded. Next slide, please. So we started our interventions together with those of the Bentiu IDP camp, and because of the same reason that there was an upsurge in malaria cases. So by the time we intervened, there was 33,664 malaria cases reported from the health facilities in Bentiu, and with the passage of time and with the interventions of larviciding, the accompanied awareness sessions, and the IRS campaign, the malaria cases, when we stopped interventions due to funding in 2019 were 3,874. So from 33,664 in 2015 to 3,874 in 2019. But unfortunately, there was no funding available in 2020 and 2021, and the malaria incidents started to increase. In 2022, we received funding, but that was only for the IRS campaign, and we have conducted IRS campaign. The malaria incident in this graph is up to week 35. It looks to be increasing, but when we have done the analysis, so the malaria cases here have been currently have reduced by 1.4% from that of last year. So we are seeing some impact, but we will see with the passage of time like if the malaria cases will increase or decrease, but there was no supplementary IRS funded or done. Next, please. Maban, we started integrated vector management intervention in Maban in 2012 when there was an upsurge in malaria cases, and we were asked by the UNHCR to come and intervene. So in late 2012 and 2013, we conducted only the larviciding campaign because by then we were not actually ready. So from that onward, we started receiving consistent funding, and then we started implementing the full package of IUM interventions. Maban currently has 4 refugee camps, and it is hosting a population of 174,000. Shelter made from thatched wood and mud plastering, and the shelter map is not like those of Bentiu. It is not as organized as Bentiu, except one camp, which is Kaya. And the other problem with Maban is like it's receiving flooding since 2019. Like we've been seeing regular flooding, which is affected not only the host community, but also the 3 refugee camps, Doro, Batil, and Janrasa, and Kaya is somewhat saved from the flooding up to now. Mosquito breeding sites are located everywhere in the camp. Next. So as I mentioned, we have started operating in Maban since November, December 2012. And we do the same kind of interventions, IRS, LSM, and we do fly control and awareness session. Up to 2020, we also had a medical component whereby we used to do VBD case management trainings for the health partners operating in the refugee camps. And we also used to provide them RDTs and ACTs on gap filling basis. It was a good interventions. No partner ever experienced any stock out, but later on, because of funding issue, we had to remove that component in 2021, where we received funding only to do the IRS campaign. Next. And our major and only donor in Maban is BPRM. So this is the same slide, which shows impact of IRS interventions. We started with ICON, we used Actelix, we used FECAM, we used SomiShield, and this year we are going to use, we have actually used Fludura Fusion, but I could not get the data for 2022 to make it part of this analysis. So if you see like this increase in the malaria cases, like say 2016, we see a high increase in malaria cases, but this was because of some of the issue in delivery of the insecticides to the country, because by then there was a major security issue in the country, and the government put some kind of embargo on any importation of any commodity to the country. So that affected our supply chain, and we could not get the insecticides on time. And then 2014, 2015, our funding cycle was not good enough for us to start the IRS campaign, like say before the rainy season. So the funding cycle was such that we had to start IRS campaign sometime even like say just before the start of rainy season, and we went into the rainy seasons to complete the IRS campaigns. So from 2017 onward, we have been receiving funding at the right time, and we are implementing activities at the right time. 2019, if you see the graph, it shows a bit of increase again, but this was the year when Maban received flooding for the first time. So it affected, as I mentioned earlier, both the refugees and the host communities. So this could be the reason that we see a bit of increase in malaria cases. But overall, I would say that IRS larviciding, when it is done at the right time, is very much effective in lowering down the malaria cases within the IDP and the camp setting, as can be seen from these graphs. Next, please. So these are some of the pictures which we have taken recently in Maban. The area is flooded every year. So this is what we see after each flooding. And then we see a lot of misuse of mosquito nets. You can see people are catching fish with mosquito nets. And it's also like the aftermath of the flooding means plenty of breeding sites for mosquitoes. So we expect an increase in malaria cases after every flood if we do not do any herbiciding. If IRS was not done before, so this can cause a huge upsurge in malaria cases in such kind of settings. Next, please. So this is another picture from within Maban refugee camps. These are some of the operational challenges that we face. Like you can see, we use these kind of roads, and we have to navigate these kind of areas to go to the beneficiaries. And in one picture, you can see this tent is supposed to provide protection to the inhabitants, but instead, if you see the water down there, this provides a conducive breeding site to a mosquito. Mosquito can breed, can lay eggs, and can increase in number, and can increase malaria cases. So instead of protection of this, this shelter is supposed to give to the beneficiaries, it provides an ideal breeding conditions for the mosquitoes as well. We know that malnourishment and malaria, when they are together, they can cause devastating effects on especially children under 5. So the people in these IDP camps are dependent on the ration that they get from the UN agencies or the INGOs. So mostly people in the camps rely on those, and whatever they get locally, like in this picture, you can see the greens that are dried and can be eaten, and later on are the food that these people take. Like for example, in the South Sudan as a whole is going through food insecurity. Like the projection from April to July 2022, there were like 1.3 million children under 5, and 676,000 pregnant ladies were estimated to be under IPC 3 or above. So you can imagine if malaria is there and malnourishment is there, so it can create problem for those communities. Next, please. We have done
Sajid, if
yes.
it's possible to just wrap up in a minute, would be appreciated. Thank you.
Okay. We have done 2 rounds of susceptibility tests in 2015 and 2018, and later on the tests were done by the NMCP in 2019 and 2020. And we, whenever we decide about which insecticides to be used, we look into these results and we decide on the selection of insecticides based on the results of the susceptibility tests. Next, please. So these are some of the pictures from some of the location, and if you have any questions, feel free to ask. Thank you so much.
Thank you, Sajid. That's much appreciated, and very interesting to look at the integrated vector management being implemented by Mentor within these refugee populations and the adaptations you needed to make. I think we'll hold questions still. Please feel free to put them in the chat. We'll hold questions until the end. So now we're going to move on to one of the case studies that we did develop. But this is presented by Dr. Jim, who's the malaria program specialist from PMI Cameroon. Dr. Jim, are you available? Ready?
Yes, please. Thank you, Joe. I'm going to present to you the ITN mass distribution campaign in the humanitarian context. the challenges and some of the lessons learned that we've had from the Northwest region of Cameroon. Slide, please. So this is the outline that we're going to follow. Slide. So the Northwest region of Cameroon is one of the 10 administrative regions of the country. And together with the Southwest region are the English parts of the English-speaking parts of Cameroon. So these two regions are the ones that have been involved since 2016 in an armed conflict between non-state groups, armed groups, and the regular military. So this region, as you can see, has a population of over 2 million, and children under 5 represent over 15% and close to 4% of pregnant women. So the health map of this particular region shows that we have a whole lot of health facilities, 61% of which are public facilities, 21% are confessional, which is very important. And then we have 18% that are private. But most importantly, we have a very large network of community health workers that are supported mostly by the Global Fund in 15 out of the 19 to 20 health districts that this region counts. Slide. So when we look at the morbidity due to malaria in this region, we can see that the capital city, Bamenda, which is in the middle, has a relatively lower morbidity, and the highest morbidity is found in the regions that are found in the peripheries. And we have regions that are very dense, that have a very high transmission of malaria. Slide. So in terms of epidemiology, Cameroon is one of the 11 countries in the world that bears about 70% of the global burden of malaria. And because of that, Cameroon adopted the high burden to high impact approach that is recommended by WHO and the Rollback Malaria Partnership. And in this approach, the country carried out a modeling exercise with support from the WHO. And as we can see from the map, we were able to stratify the country into different epidemiological strata, depending on the risks. So the country counts about 200 health districts, and each of these districts was classified depending on the incidence of malaria, the all-cause under 5 mortality rates. And after this risk classification, we were able to come up with interventions tailored subnationally. And we can see that ITNs, bed nets, are kind of cross-cutting through all of the strata, which makes the use of bed nets a very common vector control intervention in Cameroon. As a matter of fact, it's the main vector control intervention in Cameroon. We equally have in our National Strategic Plan, IRS, but yet to be started. We have equally lava source management, which is under study. But due to problems of funding, those particular interventions have not yet been rolled out in Cameroon. So we can see here that we've had our national strategic plan for the fight against malaria, but we are yet to develop a specific strategic plan for the fight against malaria in a humanitarian setting. Slide. So the entomological profile of the country is very important to understand the distribution of the bed nets in the country. I think some work was carried out that was funded by PMI, and that work consisted in coming up with the specific resistance profile for vectors in Cameroon. And using that resistance profile, we were able to identify areas that will be will benefit from the use of different types of nets. We have the PBO nets, we have the standard nets that are just pyrethroids alone, and then we have the next generation net, which is a combination of 2 different classes of insecticides. And as we can see, the Northwest region is most likely going to benefit from the next generation nets because very few studies have been carried out in this particular side of the country due to the crisis. And so it is not very certain if the vectors that are here are going to be sensitive to pyrethroids. So to be very safe, it is recommended by the National Vector Control Committee that we have to use next generation nets in the Northwest region. So that is just one of the advantages of having a vector control committee nationally that is able to sit down and make such recommendations to the NMCP so that they can actually follow evidence in allocating nets to different parts of the country, to different ecologies of the country, so vector control can be more efficient. Slide. So the humanitarian context in Cameroon is particular because here we are having a situation of an armed conflict. As a matter of fact, most of the humanitarian crises in Cameroon are generated by armed conflicts. And in the Northwest region particularly, we've had this armed conflict ongoing since 2016, and as we speak, it's still ongoing. And we've had several internally displaced persons, as you see from the last report that I exploited in 2018. There were around close to 700 internally displaced persons and 58,000 refugees. What is peculiar in the Northwest region is that these internally displaced people do not really find themselves in camps per se, but they are embedded within the general population, which implies that we have households that become larger, not only in the country, but in the other, not only in the Northwest region, I beg your pardon, but in other regions, we find that the displaced persons move and stay with their relatives in different households. So we have several health facilities that are closed, making access to some of these preventive vector control methods very, very challenging. And then the absence of qualified staff is equally a very significant problem. So all of this contribute to this disruption of the service delivery on a daily basis, and consequently the deterioration of the health indicators. And as we can see from the last demographic health survey in 2018, household ownership of bed nets was at 48%, which is quite low. So the table that you see next here is a table that just comes up with the risk stratification according to the perceived risk from the different stakeholders in the health districts. You see that some of them will find that health facilities are even maybe like 90% functional, but yet the risk is quite high, which means that it was quite challenging for us to be able to come up with criteria that can be very, very strong to classify risk, because even in areas that you had a very high proportion of health facilities that were functional, it was not enough to say that there was no problem. The risks still remain quite high. And so this is what guides us in order to come up with how to approach the distribution of bed nets in such an area. Slide. So in order to understand how to approach a bed net distribution campaign in the Northwest region, we had to understand the characteristics of this armed conflict. And these characteristics were, amongst others, we have the frequent armed attacks, crossfires. There is an increased number of persons per household, and that is because of the displacement of the people. And what is important to notice that it is not very predictable. People will move from there. There are higher frequency of armed attacks to areas where there's a lower frequency of armed attacks. So where the security levels were lower, there were more people that moved towards those areas. Then it was unpredictable. This population movement was unpredictable, so it was not easy to plan. Several activities, socioeconomic activities, were interrupted, and we have equally the increased cost of living and transportation. That is very important, because when we were trying to do the planning for these campaigns, it was difficult to know exactly the costing, because while you think that the cost is maybe 100 friends. When you get there, the cost has tripled overnight because of the security risks that is being perceived. So with all of that, we came up with a contingency plan for the implementation of a mass campaign in such a setting. And this was through a lot of consultations, taking into consideration the environment in which we were operating. Slide. So the campaign itself was organized using a door-to-door strategy. And in areas where we had a high security risk, we used a fixed post hit and run strategy. Now, it was very important to note that in the allocation in the decision of the strategy, we had COVID-19, which was really very high at the time. That was in 2020. We had COVID-19, and then we had areas where the security risk was relatively lower. And we had areas where the security risk was higher. So where the security risk was lower and due to COVID-19, we used a door-to-door strategy. Then where the security risk was much higher, and notably where the population density was very low, meaning that there were populations that were living in very far distances from each other, we opted for a fixed post hit and run strategy. And in the hit and run strategy, we had to go in and do a head count. And the following day, the people who have been counted go to a fixed post and collect their bed nets. And we did that from one quarter to another. So these campaigns become very, very expensive because it is very labor intensive. You need a high number of human resources to be able to accomplish this. Slide. So we had a very important need for coordination during this campaign, and we had to mobilize the national coordination committees, and we had to equally mobilize the regional coordination committees. Now, these coordination committees brought together actors from all the sectors. And I would like to highlight, yes, the security sector, which was very important because actors had to go down to the field and sometimes it needed security. And then we had the regional coordination committees chaired by the governors of the regions, and it brought together several actors. And one of the most important actors here was the religious authorities. The religious authorities, because churches were those structures that were still very accepted in all the communities, while most of the other structures were disrupted. And due to that disruption, we carried out at the district levels, means below the regions, we had to do a lot of advocacy. And those were very important meetings at district and health area levels that occurred at several stages during the campaign. It was not just meetings that occurred once. So that advocacy meeting was important because it helps us to do a proper stakeholder analysis, given that most of the stakeholders that we knew in those areas had either run away, some died. So we had to do a stakeholder analysis at each stage of the campaign and map all the stakeholders and assets in order to harness them and use them for the success of the campaign. There was a very, very big problem with mass communication because about 70% of the community radios were closed, so it was not possible to communicate. So the campaign now was put in different phases. We did not take the whole region at the same time. We tried to progress in phases so that we can learn and then adjust in the following phases so we do not commit a very big error. So it was actually a learning by doing process. Slide. So we had some major outcomes, and I will just highlight a few. We were able to distribute about 88% of the nets that we planned to distribute, and that was quite impressive. We counted about 104,000 internally displaced persons during our campaign, and there was a very serious community engagement through the advocacy meetings. We think that it was during these advocacy meetings that we were able to profine the strategy for the campaign, because due to the crisis, the roads that we thought that are normally used were blocked, and the new roads that people used to move were indicated to us during these advocacy meetings by the population. And the population during these advocacy meetings equally chose the channels through which communication could pass easily. So that was quite one of the biggest outcomes of the advocacy meetings. Then, with the help of the AMP, we were able to really respect the WHO COVID-19 preventive measures, and they were able to help us to implement this properly while giving a very tremendous support to us to harness all the information from the meetings and come up with a good strategy for the campaign. Slide, please. So some of the enabling factors, what I would say is we have this high political commitment from the government and the support from the Global Fund. And I would also add from the Alliance for Malaria Prevention that accepted to really carry out this campaign, because from the beginning, nobody had a particular strategy to do this campaign. But with the commitment from the government, we're able to sit down with the community and come up with a strategy through the advocacy meetings at the level of at right from community level. So one of the enabling factors equally was the fact that the population awareness about malaria was quite high and the perceived severity of malaria was quite high. So they were able to come in and support the campaign to succeed in this context. Then we have equally the micro planning that began at community level. It did not start at regional level as usually the case is, but it was really a bottom to top organization of the campaign. Then we had to adapt our recruitment criteria for actors. You see that we were able to realize that it was important to use more of women than men, because in such a conflict, men were often suspected and some were arrested without any just cause. So it was that gender approach that helped us to equally come up with some success during the campaign. Slide.
Dr. Jim, if you're able to just wrap up in 1 minute, that'd be appreciated. Thank you.
No problem. Slide, please. So some of the barriers and how we came up with is just, I can just say here that we had to study our environment, identify the challenges, come up with solutions together with the community. And all these solutions that we present here were really defined with the full participation of the community. Slide, please. So the lessons learned, I think I've already highlighted some of the lessons learned. And it's just important to say here that community participation was very, very essential for the success of the campaign. Slide, please. So the perspective here, and this is important because this year we're going to be distributing 1.5 million bed nets to the same region. And one of the things that we have learned and we are going to be applying is understanding the characteristics of the crisis, stakeholder analysis and advocacy meetings, proper micro planning. Then we're going to increase training needs because it's a new strategy and needs to really be understood and anticipate increased household sizes. And then we're going to involve religious bodies because that's the excellent communication means. Phase out the campaigns as much as possible, develop new tools for distant supportive supervision, and then take into consideration the possible modification in implementation cost and look closely at the accountability mechanisms. I think that with that, we can say that we could try campaigns in these settings as much as possible. Slide, please. So these are just some of the pictures that we had from the campaign, and we appreciate, most importantly, the population of the Northwest and its religious and administrative authorities, as well as our donors for the support we received. Thank you very much.
Dr. Jim, thank you so much. Super interesting and important to see the community level involvement in supporting the BedNet distribution campaign. Okay, so just quickly, we're going to just quickly touch on our other two case studies that we developed. Jess, quickly over to you, Mom.
Hi, thank you, everyone. It's really nice to see such a great turnout for this webinar. Next. As Joe said in the beginning, we have really focused on trying to put enough evidence through case studies made available to also expand upon the work that the UN Foundation has done. So with UNHCR in Uganda, we developed a case study to highlight the work that has been done to protect refugee settlement camps and host communities of 1.5 million refugees, and that was in 2022. Clearly, they have been focused on this since the COVID-19 context, once all of the refugees started coming into Uganda. You'll note that the population is not only South Sudanese, but also from DRC and Burundi. As noted, and not surprising to this group, malaria is the leading cause of morbidity, accounting for 30% of outpatient, 60% of inpatient, and 701,000 cases of malaria and 129 deaths, meaning that represents 12% of the overall deaths among the refugees in Uganda. Next slide. I won't really go through the lessons learned because I'd rather drive you. I want to have time for question and answer, and I'll drive you to the AMP website where you can see all of these case studies. Next. We'd also like to acknowledge the work of PATH with malaria, with the Mozambique NMCP or PNCM, I should say, with ALMA and USAID and WHO on developing this case study, which we've also put into a formatted Word document. As you know, Mozambique is one of the 11 high burden countries with 4.2% of the global malaria cases and deaths. With the onset of Cyclone Idai, it affected more than 1.8 million people and damaged 62 health facilities or destroyed them. 239,000 homes were destroyed, and that led to 100,000 in temporary camps. What we really came out of the Cyclone Idai process is the need to really prioritize the cluster system, and that there needed to be more preparation for malaria prevention once the water had receded. Malaria was not prioritized at the time, but I have to say with the leadership of Dr. Candrino and many others, there was an amazing amount of work done. So again, just to say that all of these case studies are on the AMP website, and we would appreciate you taking a look at those and providing any questions or comments. So Joe, I'm going to end it there. I think the next slide says it all, though. One more, if we don't do it, who will? I think this is, I know it is work that we will continue to undertake and amplify as we go into the next series of roundtables to ensure that we are meeting the needs of IDP, refugees, asylum seekers, and all of those at risk from malaria. Thank you very much. Joe, you're on mute.
Yes, thank you, Jess. We appreciate the quick highlight of those two country examples. Please, again, go to the AMP website under the COE context. In the policy tab, you will see where these case studies sit with other ones that have been developed during COVID. Okay, so questions from those who are either monitoring the chat or would like to come off mute. Yeah, please feel free to answer the questions about either the roundtables, the work that UNF is doing, or the country examples that you heard.
So Ule, I think your question on integration of IRS and larvicide campaigns in South Sudan was answered, but if you don't feel that way, could you please ask again to Sajid, if you're still on, Uli?
Yes, I'm still on. Can you hear me?
Thank you. Yes, can hear you loud and clear.
Yes, I think it was responded, but I would like to know if other organizations like then Mentor try different tools and combinations to see what works and what not. Thank you.
I think based on our
yes, for you, Sajid, I think it was clear. My question was other organizations, have they done similar comparisons to find out what works best? Maybe Jessica has a review.
Yakuba, you had a question, I think, for Sajid.
Yes, it was. Sorry, it was also for you, because Sajid, as you said, responded quite clear that the combination of IRS and larvicide was effective and bedness were not. And my question was, is this a general experience from refugee camps?
Sajid, I think that you can, on behalf of Mentor, with all of Mentor's experience, respond to that question that Uli just asked. I know the answer, but I'm going to let you do that because you work for Mentor.
And I think Dr. Jim could also add from his perspective about the
yes.
effectiveness of the nets if they have any evidence from their side. And thanks to all the presenters. Over.
I think based on our experience, like it could be no use or misuse in these settings. If you see the Bentiu graph, LLN have been distributing every now and then, but still, like say, for example, in 2020, there was no IRS. LLINs were distributed, and those were like the PBU LLIN, but still we see that the malaria cases were on the up. And when we conducted the IRS campaign, it came down in 2021. So I would say in 2021, if you see like IRS was on the up again, those people might have still be using those PBO LLINs which were distributed in 2020. But if just imagine if you are not there, if you would not have done the IRS campaign, then I think in this kind of setting, because of no use or misuse, LLIN would not have that kind of effect. Thank you.
Dr. Jim,
Yes,
would you like to respond?
Yes, if I may just add to that, we have currently started the malaria indicator survey, and it is ongoing. And so we are hoping that the results will permit us to do a clear comparison with the results in 2018 from the demographic health survey and have a more objective measure of how effective the LNIS is contributed to the reduction of the morbidity. I think that that's the most important measure that we are waiting for. So at the moment, we can say looking at just the routine data. But there has been some reduction in the morbidity due to malaria in those regions and the mortality in the Northwest region. But we wait for the results of the malaria indicator survey to be more certain. Thank you.
That's great.
Okay.
Thank you. Sajid, Dr.
Yakuba,
Jim.
are you still online? Okay, Fikadu, I'm going to go to you. Oh, there you are, Yakuba. Would you like to ask your question?
Yes. As you know, most of the time in the insecurity areas, you have the issue of how to hang the ITN in IDP sites. Are you able to hear me?
Yes, we are.
Yes. I'm asking how do you deal with the hanging of ITN in IDP sites? And another problem is that in this insecurity setting, while we are registering the household, IDPs continue to arrive during the household registration. How do you manage with this kind of situation in security setting? Maybe this question can be addressed to all of you. Over to you, all the presentator.
Dr.
Sajid,
Jim.
would you like to go first?
About use of LLINs in those settings?
Hanging.
hanging, I think hanging in, for example, maybe in the first phase of any emergency, like say in the tents, could be a challenge. But once we have some time, IDPs or refugees living and they put up their own structure, then I think there won't be any problem. We have not seen any problem in hanging of daily lions in those rooms, whether round one or rectangular one. That I'm talking about the room type. So yeah, initially maybe when they are living in tent, it could be a problem if they are many in number. So, but later on when they put up their own structures, I think it won't be a problem. Thank you.
Yes, just to say that we have a continuous distribution of bed nets strategy equally, which happens during antenatal care for pregnant women and during infant welfare clinics, vaccine immunizations for children up to the age of 2 years. So that mechanism in between campaigns, when the IDPs are coming into the homes, we will prioritize those who are pregnant and give them bed nets, and the children equally, we give them bed nets within the framework of the continuous distribution within routine or ongoing health systems. Thank you.
Can I ask a follow-up question, Dr. Jim? And maybe, yeah. So in terms of, it's great that we're distributing to pregnant women and children under 5, as you know, people are still moving. But would you have a recommendation for something that would be more effective in these conditions where we do have constant population movement and we're reliant on certain cycles? Are there different things that you would recommend that we do? And the question's for both Mentor and for Dr. Jim, but you know, routine is one thing, it's not getting us to very high coverage. So are there other things you think we should be doing? Over.
If I may go first, I think it is very important to already enhance communication around the importance of using the bed net. Let the bed net be part of your luggage if you are to move, because the bed net is very portable. And in case people who are displaced cannot be able to move with bed nets, because I know insecurity situations are very dramatic and it's difficult, we need to engage communities to be able to map all the areas where we have IDPs that are arriving, because only the communities can tell you, especially when they do not have a particular settlement. And if there is this community surveillance system and reporting system that is put in place, we can now engage with the community authorities to come up with special measures to make available contingents of bed nets that can be used to take care of these communities when they receive the bed nets. So I think a very important community approach is going to be necessary to be able to identify, map, and then intervene with such sporadic displacements. Thank you.
Okay, do we have any other questions for either speaker?
If I may, Jessica, this is Radu.
Hello.
Thank you, presenters. So they have answered my question, but how do they like accurately identify those people who are IDPs but living with their relatives? Wasn't it a challenge to really distribute specifically for those IDPs, just leaving out those people who are permanent residents of the area? That's one question. The other question is, especially in Cameroon, Jim said that the strategy was to have one item for 2 individuals. How does it really make that resource available for constantly changing number of IDPs regarding the limited, probably limited number of mates? This was very big challenge for us when we tried to address the net distribution in Pakistan recently, because the number of nets that we had in the country and the number of the IDPs that we have were not in proportion, and so they're not matching, and we had to change the strategy to just target some individuals who are probably more vulnerable to malaria compared to the other populations. So I would appreciate if they would reflect on these points. Thank you.
Dr. Jim, do you want to answer that?
Yes, please. It's a very difficult exercise to identify IDPs. But the first thing is, since we opted for a door-to-door campaign, during this door-to-door engagement with the households, we were able to identify those people who were IDPs and who came. True, it was not predictable. People moved from areas where there was relatively higher insecurity to areas where the insecurity is lower, which means that during the micro planning, we were not able to anticipate where the war will be hottest and where it will be softer. So we planned directly, but when we were able to monitor as the campaign unfolded, we could see that there was a lot of nets in one area or in one health district compared to another. So we had to redeploy the nets. And so that's the challenge. You can actually not predict where the movements are going to go. But if you look overall at the resources for the campaign, the difference may not be too high. The country equally has a Department of Civil Protection that is with the Ministry of the Interior, and they generally have their own database and registry where they ask people who are internally displaced people to come and register themselves. But that takes a lot of time. So you need to be able to engage during the door-to-door exercise to identify the people who have added to that household. And that brings up the issue about the threshold. How many nets can you give maximum per house? I think it was a very hot question with the NMCPs because they had a ceiling of 4 nets maximum per house because they were like, if people are more than 8 in a household, it's rare. So they said, okay, we should have a ceiling of 4. But when we got to the field, we saw that people were above 10. And so it was difficult, and all of those are lessons learned for the subsequent campaigns to know that we could reach a situation whereby we have averagely larger households than normally. And so we should just factor that in our planning and see how it works out. Thank you.
Okay, Joe, I see we're at a little over time. Do you want to talk about forthcoming roundtables and close the meeting? Thank you, everyone.
Sure, Jess. Thanks, everybody. And thanks for those additional questions. And thanks for everybody who's sticking on the line. Yeah, so I just wanted to briefly mention some kind of ways that this topic globally is coming together. You know, we're seeing from the need for improving the operational delivery of vector control in COE settings, something that AMP and others are well placed to help support. We are also looking at ways to increase financing for the gaps that still remain for vector control tools within vector control commodities within humanitarian settings, and then improve coordination. I mean, we have opportunities, like I said, among the vector control community, but bringing and ensuring better coordination with our humanitarian response partners will be important to ensure that commodities get to these populations. So with that, I think we've got a number of activities happening at least through the first quarter of 2023. In December, we, in conjunction with CRSPC, are hoping to present these activities along with others are at a second roundtable in Nairobi. So this will be a great opportunity for us to ensure that we have countries thinking about and writing in activities to distribute ITNs and other vector control commodities within their IDP and refugee populations. And then in February, we'll have the RBM vector control working group meetings and the multi-sectoral working group meetings happening in Accra. And then finally, there will be the TRP meetings where we'll also hopefully have ways to ensure that we are building these type of activities into upcoming Global Fund grants. We look forward to speaking with the partnership and others about other opportunities, whether that be in the humanitarian response sectors or other vector control sectors, other donors or others around ways that we can help move forward this agenda. I just want to close by saying thank you all for the time that you've taken to spend with us today. Thank you to our presenters for the incredible work that they're doing and what they presented on. And thank you to A&P for continuing to move forward on this agenda, and look forward to sharing more with you and the emerging, the Innovation and Evaluation Working Group on what we'll continue to do under this space. Thanks again.
Thanks, everyone. Margaret, if you're still on, that's for February in Accra.
Thank you. Great job. We really appreciate it.
Thanks, everyone. Really appreciate it.
Thank you.
Bye-bye.
Thanks, everybody.
Thank you.
Bye.